Good evening, everyone.
Muy buenas noches.
Good evening,
¿Cómo
everyone.
están?
How are you?
Hoy son las 19 horas
It
con
is
un
7
minuto
p.m.
del
with
martes
1
5 de
minute
mayo,
of
día histórico del aniversario de la
Tuesday,
batalla de Puebla.
May the 5th,
Y
which is the
estamos
anniversary
ubicados
of
en
the
la Ciudad
Battle
de
of
México,
Puebla.
en la Ciudad de México, y vamos a iniciar la
We are in
conferencia
Mexico
de prensa
City,
diaria
and let's
sobre la
begin with the
situación
daily
mundial y nacional
press conference
de
regarding
la
the
pandemia
world
de
and
COVID,
the
que también
national
causada por el nuevo
situation
coronavirus SARS-CoV-2.
of COVID,
Y hoy
which
vamos a
is the
tener
disease
tres
caused by
elementos.
the new coronavirus
Tenemos el
SARS-CoV-2.
informe técnico de todos los
We'll be
días que
presenting
presentará
the
el
daily
doctor
technical report
Alomía.
that will be in charge of Dr.
Tendremos
Alomia.
una presentación por parte del
Then we'll have
doctor
a
Alejandro Calderón
presentation by
Aripi,
Dr. Alejandro
coordinador
Calderón Aripi,
de
who is the
abastecimiento del Instituto de Salud
coordinator
para el Bienestar, sobre la distribución de los insumos que se
of the
preguntaba esta mañana y lo hemos
supplies
comentado
section
varias veces.
of
Y
the
también bienvenido
of the
licenciado
INSABI, of the
Aripi.
National Health
También nos
Institute,
acompaña
Health and
nuestro
Wellbeing
querido
Institute.
amigo y
He'll be
compañero,
sharing
el
some
doctor
information about the
Víctor
logistics
Hugo
of
Aburto,
the medical
director de
supplies.
prestaciones médicas del Instituto Mexicano del Seguro Social.
And
Y
we
vamos a
also
presentar
have
dos
our colleague
elementos que no les
here
digo
who
cuáles
will
son
be
para
sharing
no
with us some
quemarla.
very special
Son
information
noticias
that I won't be
positivas sobre lo que
revealing
está
right now,
haciendo
but
el IMSS
there are
al
two
respecto.
positive
La
surprises
velocidad
about
con que
what
vamos a
IMSS
presentar
is currently
el
doing,
aplanamiento de la curva
and I
para
won't
mostrárselos de
reveal
manera
any
muy
details.
gráfica, muy clara,
And
con
later, if we
números
have enough time,
tangibles.
I'll be showing evidence
Doctor
of the
Alomía, con gusto.
flattening of the curve that we've been talking about
Muy
today.
buenas noches a todas y
Good
todos.
evening,
Iniciamos
everyone.
rápidamente con el cuadro que nos
Let's begin with
pone el
the
día en el que nos encontramos.
calendar.
37 es el número de la conferencia
This is the press conference number
44 días
67,
de haber iniciado la Jornada Nacional de Sana Distancia. En la siguiente
and this is the
diapositiva
44
vemos, la actualización
day
del
44
índice
since
de
we started with the
contagios.
national campaign of safe distance and prevention
Reducción de
measures.
un punto porcentual más, 32% los casos
The
confirmados en
international
los últimos 7 días
context,
en todo el mundo.
we can see that
Contrayéndose la
the active
pandemia
pandemic worldwide continues to
la región de las
go
Américas
down.
está
We are at a 34% now,
más de la mitad de todos
and
los casos en el mundo
more
que se
than
han
half of
observado
these active
en
cases
esta
are
temporalidad
belong to the Americas,
la transmisión
which
a
we are at a
en la siguiente
51.5%
diapositiva
representation of
los
active
números
cases
nacionales,
worldwide. The
26.025
national
casos confirmados.
data
Estos son los casos acumulados
up to now
hasta
is
este momento, desde que iniciaron, pero resaltamos que son solo
26,025 confirmed cases,
6.708 que
but
representan
out of
una
these,
cuarta parte
only
de este total, son aquellos cuyos
6,708,
síntomas
meaning
presentados
1/4
por
of the
señales.
total
La
confirmed
epidemia
cases,
activa en
are
México,
the active cases in Mexico. That is the
2.507,
active
lamentables
pandemic in
defunciones, se han
Mexico.
ocurrido
Unfortunately, we've had
63.507
2,507
son los resultados
deaths.
negativos que se han
We've had
acumulado y ya son más de
63,540
las personas que han sido estudiadas e ingresadas
negative cases,
para el tema de
and in total we have studied
La siguiente diapositiva vemos
105,000
la
people.
carga de enfermedad por entidad federativa. Ya veníamos comentando que en las
Here we
últimas
have the burden
días,
of
la última
disease
semana, vemos
distribution
cada
per
vez
state.
como más entidades federativas presentan este color
We can
rojo,
appreciate
que
how
representa un incremento
uh,
arriba de los 250, 500
there are more and
casos.
more
Bueno, esto vamos
states that
desarrollando
appear now
de
represented
esta
in
manera
orange
medida
and even
que
red,
la epidemia en México
meaning
continúa.
that they have higher
La siguiente
concentration
diapositiva
rates
es una
of the
diapositiva de
disease.
referencia para que ustedes
Here we
puedan ver
have
los
the same
números en total que
information
están en
as a bar graph,
en la siguiente
presented
diapositiva
as a
vamos a
bar
ver el
graph.
mapa con distribución geográfica de la
Here we
epidemia
have the
activa,
geographic
esos
distribution
6.708
of the
casos.
active
Podemos
pandemic,
igual
meaning
ver
those
otras entidades federativas,
6,708
empiezan a ubicarse también
cases we
en
were referring
orange,
to.
significa
Some
que han
states appear
pasado
now
la
in
barrera de
orange,
los 100
meaning
casos
they
y
have
continúan
surpassed the 100
incrementando
case
su carga de enfermedad.
barrier,
En
and
la
they continue
siguiente
to
diapositiva vemos esta
increase
misma
their
distribución
burden
con
of
los
disease.
datos completos y en orden
Here we have the same information presented as a bar graph for you to be able to appreciate the number that corresponds to each state specifically. Here we have the incidence, the active pandemic incidence rate, which, as you may recall, is the number of active cases per 100,000 inhabitants per state. And we can see how which states have a greater affectation than others. The average incidence rate has been 5.24 nationwide. We have the same information presented as a bar graph, so you can quickly identify which states are leading the way in the active pandemic incidence rate. Following slide, we have the distribution of the fatalities, the cumulative fatalities, the cumulative death toll so far, which is 2,507, and we still have 224 fatalities that are currently considered suspect, meaning we are waiting for the results in order to either confirm or deny that they were caused by COVID-19. The suspect fatalities are represented in the with the color orange, light orange, and the blue part are the confirmed fatalities. Next slide, we have the same distribution of these 2,507 fatalities, but now we can clearly see which fatalities belong to which states and which states still have suspect fatalities that are yet to be confirmed or denied. Here we have the suspect case and the confirmed case distribution. Suspect in light orange, confirmed in dark red, and as we have been saying, a good amount of these suspect cases will eventually be confirmed as positive COVID-19 cases, and they will be incorporated into the red bars. Here we have the general pandemic curve for the cumulative confirmed cases, which, as we said, to this day is 26,025 confirmed cases. We've had 1,120 new confirmed cases in the last 24 hours, which is an increase of 4.5. And we continue to see an upward trend. Here we have the information regarding the hospital bed occupancy rates. We're dealing with 14,088 beds that have been equipped to provide treatment specifically for patients with acute respiratory infections, and out of these 14,088, we have 6,471 that are currently being used, that are occupied by patients. So we're talking about an occupancy rate of 31%. And the notification rate stands at 96%. Here we have the distribution of this occupancy rate, and we can see how there is a great variation amongst different states. Mexico City, Baja California, the state of Mexico, and Quintana Roo are the four states that are leading the way in the occupancy rates, and they've shown gradual increase over the past few days. Here we have the ICU bed occupancy rate per state, and we still see Mexico City, Baja California, Sinaloa, and the state of Mexico are the top four states with the highest occupancy rates. The average occupancy is 25%, but in Mexico City we're looking at an occupancy rate of 58%, which is the highest in the whole country.
Sería la actualización para el día de hoy.
Muy bien. Gracias, doctor Alomía.
That would be my information for today.
Dos diapositivas nada más para comentar.
Thank you, Dr. Alomía. I will be presenting only 2 slides to convey some relevant information about the flattening of the curve. There is a misconception regarding the flattening of the curve, and I would like to show again an image that we presented, I think, in January and in February. That is the theoretical foundation of pandemic behavior and of pandemic control. This is an epidemic curve, which, as you know, it is a visual representation of the occurrence of a phenomenon that is of public interest within the health sector. In this case, specifically referring to a pandemic. And this comes from very substantial scientific evidence that we have accumulated over decades worldwide regarding the behavior and the control of pandemics. So we have a good amount of scientific evidence that supports the different courses of action that must be implemented in order to control an epidemic. And remember, when an epidemic reaches several countries on a global scale, then we call it a pandemic. There are two important aspects. One of them is the contagion, which basically means focusing on suspect cases, identifying them early, and then study their contact network. These contagion measures are very useful, especially in the beginning of an epidemic or of a pandemic, when we can identify all of the contagions. But the time comes in which there are so many contagions that they cannot be identified one by one, and then we implement massive mitigation measures. We also call this community mitigation. These community mitigation measures are based on the social distancing mechanism that in Mexico we have referred to as safe distancing or safe distance. And this is one of the characteristics of the transition between phase 1 and phase 2, that the course of action changes. We've said several times that the overall strategy doesn't change. The overall strategy is a comprehensive approach that has different courses of action that are contemplated from the beginning. But these courses of action and these specific actions are changing all the time as the pandemic moves forward. So here we have the cases represented by a curve, and we can measure the amount of confirmed cases by the height of this curve that appears represented in this chart. When we have a pandemic, it is when we have a pandemic, it is completely impossible to stop the pandemic from happening. And it would be naive to think otherwise, because scientific and historical evidence have shown time after time that it is not feasible, it is not possible to stop epidemics from taking their due course. It would be great if there was a way, but there isn't. But then what we can do, rather than stop the epidemic process, what we can do is to slow it down, to slow down the transmission rates, to attenuate the consequences, to mitigate the effects of this pandemic. So here we have the difference between the development of an infectious disease pandemic in two scenarios. One scenario is if we didn't implement any measures whatsoever. Yes. So basically, what happens is the amount of newly confirmed of new cases of new contagions every day start to increase exponentially until we peak, and usually this peak happens when we achieve what is known as herd immunity. And this could be local and temporary. This could happen in a specific city and not happen in another city. And then after a peak is reached and herd immunity in a specific locality is reached, then the transmission rates start to slow down, and then we start seeing less and less and less and less contagion. Usually, infectious diseases follow this pattern of behavior. And when the transmission rates are decreasing, they can go lower or faster, depending on a number of factors. Now, on the second figure, on the On the curve that is represented with the stripes on it, this is the curve that we can have if we implement in an effective and timely manner the different mitigation measures. Also, we have to be consistent about it, meaning that we follow a same pattern over time. For example, staying home throughout a whole period of time. If we break this rule at some given time and we stay at home sometimes and then leave home sometimes, we are more strict sometimes and then less strict, then we wouldn't have the desired effect, and we wouldn't be looking at this kind of curve because we would have setbacks. So, coming back to the theoretical foundation of how to control an epidemic, there are three important aspects. First of all, we want to delay this peak that we are talking about, this epidemic peak. Why? Because when we have a pandemic, usually the health systems around the world are not prepared to deal with something that is by its very definition extraordinary, an emergent phenomenon. So we need time in order to make the proper preparations, expand the capacity of the health system, and be able to treat all of the population. So objective number one is to delay the date in which the peak happens. And this difference that is represented on point 1 is a positive impact of the mitigation measures and also of the contagion measures. The second objective that is very important is to decrease or to reduce the height of this curve, because this height represents the daily number of new cases. And this is the maximum amount, right? The maximum number that is reached at the peak. And this is for the whole curve, but it is easier to compare when we compare the peak of the curve, right? So instead of having this peak over here, we have this peak over here. So that's objective number 2, to reduce the number of cases that are the number of contagions that happened on a single day. That is objective number 2. And objective number 3 is that the overall area of the curve, meaning the total number of cases, can decrease in some way. That is objective number 3, to reduce the total number of cases. And now I would like to show you why we have said, and we said this morning with the evidence, all the evidence in our hands, that we have successfully flattened the curve in Mexico, or to put it in a better way, we are flattening the curve. Here we can see February the 27th, when we detected the first case. I'm gonna be taking Mexico City as an example to illustrate my point. This data is relevant to Mexico City. This is not nationwide data. This is only for Mexico City, and these are real numbers of cases. The time, so on the horizontal axis we have the dates, and on the vertical one we have the number of cases. And here we have the prediction that was elaborated several weeks ago by a group of mathematicians and data scientists from different university higher education institutions. They made this prediction, and they made this prediction based on the very first cases that we had in a period of 10 days before we reached the turning point. And then by applying a mathematical transmission model, they predicted that this is what would have happened. So this is the first curve. Then the green curve is also a prediction that those same groups made And what they said is, these two predictions were like this. This first curve is what will happen if there are no measures whatsoever, and this other curve, this second curve, is what will happen if the proper measures are applied correctly, effectively, and timely. So that was their prediction. There were two predictions. So the two curves, the two lines, represent the two predictions that were made at the beginning, in the very first stages of the pandemic in our country. And then the yellow bars represent what has actually happened, what happened after these predictions. And the predictions of what is happening and will continue to happen over the next few weeks is updated constantly to have a better recognition of what will come next. Last night we were handed a new prediction which is slightly minor than the one we had before, and we'll continue to update this prediction as time passes. Finally, the numbers. Let's compare two things. Let's compare the prediction of what will happen. That was the prediction that was made on April 9th of what would have happened without any sort of action. And then also let's compare the data of what has happened, which is represented in the yellow bar, with the prediction of what should have happened with the measures. So without any sort of action, we would have peaked on April the 2nd. So it would have been 1 month, more than 1 month earlier, right? Because our prediction is that we will peak on May the 8th. And before I had said May the 6th. But then when we updated the prediction, there was an additional gain of 2 days. So now the new prediction says that we will peak at May the 8th, and that's even better because then that means the curve is even more flattened. The second point is the cumulative cases from the very first day of the pandemic in our country, which is February 28th, meaning all of these yellow bars are without intervention, without action. We would have had in this 60, according to the first prediction, in these 61 days, we would have had 38,773 cases without action, without measures. With action, with measurements, according to the prediction, we would have had 11,212 cases, according to the prediction, right? And now we can contrast these two predictions to what actually has happened, which is we have 10,268 cases during this 61-day period, which is even a smaller percentage of the first scenario in which we didn't apply any sort of measures. You know, so this means that we've had a decrease of 74% so far. So far, if we continue to comply with and abide with and implement the measures that we have been implementing and complying with and abiding with, then we will have a rather flattened curve. So I would like to say two things. To flatten the curve doesn't mean to make the pandemic go away. Whoever thinks that is the case, of course, has a very legitimate desire to modify reality, but also is out of touch with reality because is not aware that a pandemic cannot be stopped from one day to another. And also the second point I would like to emphasize, and I will end with this, that this prediction that is currently being fulfilled will continue to be fulfilled if and only if we continue to stay home and we continue to abide by all the national safe distance campaign measures, and in that manner we will ensure to remain on this curve, on this flattened curve, and not on this other curve. We still have more than half of the first epidemic cycle to go, and we still have a very important labor to do in order to ensure that our hospitals do not reach overcapacity and our medical health system does not get oversaturated. Thank you very much. Now I'll be talking about the distribution of all the purchases that we have made to deal with the COVID-19 pandemic. We are cataloging these purchases in 4 different groups. First of which is laboratory equipment and supplies. These supplies are sent directly to the INDRE, which is the institution that coordinates all the testing that is done in the federal laboratories in our country. Then we have another category of medical equipment, which is the personal protective equipment. That is the second category, with over 15 million pieces. We have a third category of purchases, which is the hygiene and disinfection supplies. And then the fourth category is drugs and medication. And this is also of high volume because patients that are being treated in a severe in an ICU unit have to be taking a large quantity of drugs and medications, and these come at a high expense. This has been distributed in the period of March the 30th to May the 4th. And we have distributed millions of pieces all across the country and through hospitals all across the country, including the hospitals that belong to INSABI and hospitals that are highly specialized in different states of the Republic. Here you can see with better detail the distribution of these supplies.
And then down below, we can see the movements between Mexico and China. You can see the first airplane came, it had 50,000 tests, and it also had face masks. And if we look from the first flight to the 7th flight, we can see our PPE equipment has been a total of just over 8 million pieces. Up to today, we know that these flights are going to continue. We want them to continue, but we've only brought 15% of all of the supplies that we have bought. And we want to get those supplies in our hands so that we can meet the demand. For medical equipment, these are the main pieces of equipment that we have acquired: ventilators, pediatric ventilators and adult ventilators, video larynge scopes, and we can see here how they've been distributed. We've acquired a lot more than this. In terms of ventilators, we've acquired more than 3,000, and for monitors as well, more than 3,000. But here you can see how they've been distributed. On the table to the right, we've also mentioned that this depends on who's going to benefit, where they get distributed. We have gotten some donations. I don't want to say which companies have donated. I don't want to leave anybody out. I'd rather make a list and mention them one by one at another time. Continuing along with the medical equipment, in Toluca, a flight arrived from the United States today with 211 ventilators, Hamilton brand. And that was thanks to negotiation that was done by our president, AMLO, with the president of the United States, Donald Trump. That first flight brought 211 ventilators of many more ventilators that are going to arrive this month. Of those, 109 are for the Health Institute for Wellbeing, and that gets distributed among different states. And we have an example here of how these 109 ventilators were distributed. They were distributed to Baja California, Tabasco, Quintana Roo, and the Navy. We gave 20 to the Navy. We distributed 20 to them for their demand. And Deputy Secretary, that is my report on the distribution of equipment. Thank you so much, Dr. Alipi. Please, Dr. Borges, could you please tell us about the two subjects that you're going to be talking about? Yes, I'm going to go over here to talk about this.
Vamos a comentar el día de hoy.
Today we're going to talk, could you go back to the other slides? I'd like to go to the risk calculator. Here we have already talked about the infection from SARS-CoV-2, and we've talked about how it can be different for different people. It could be a light sickness, some people are asymptomatic, and then we have a group of people, a vulnerable group of people who might develop the serious disease. Of these people who develop the serious version of this disease, they could be in critical care, hospitalized, they might need a ventilator, and other people may die. They might die. Who are these people who are more vulnerable? These people are in a more vulnerable group. We've talked about these people before. People who have comorbidity in the Mexican Social Security Institute. We could have up to 30,000 people who are eligible for care in the public health system. They could have diabetes, they could be obese, they could have immunosuppressive diseases. And then we also have people with other diseases that lower their body's ability to react. It's important to understand that children and adolescents react in a different way. And as we go and see people who are older, we see a higher risk of developing a severe version of COVID. And we've also seen a difference between sex, between males and females. We've seen it in Italy, and we've seen it here in Mexico as well. What did we do? We made a risk calculator. We got information from the Mexican Social Security Institute, and we took a look at two different groups of people. Next slide, please. We compared two groups of people. One was a group of patients who were in serious condition, approximately 2,000, who had been hospitalized or had died, and we compared them to people who had not serious versions of this disease. We had 2,000 who had a light version and 2,000 who had a serious acute version of COVID. In IMSS, the Mexican Social Security Institute, we receive a daily report and how patients are doing at their hospitals. And we've done this for over 2 weeks. We were comparing these patients. We compared their backgrounds. And you know that when we take a sample, we do an interview with people. It's called an epidemiological study. In that epidemiological study, we take a look at different variables, a series of variables, and we see how they affect each group. We take a look at the logistics, we talk to the epidemiologists, and we see what are the relative risks? How related are they? How related is one variable to another one? And this is what we obtained. One thing was relative risk. That's what we talked about, which talks about how much your risk increases to have this disease if you have certain characteristics. That's on the left. And then we calculated another fraction, which is what we would attribute to another part of it, and I'll talk about that later. Men, they had up to an 81% higher risk of developing serious COVID than women did if they get infected. In terms of age, each year older than you are, older than 20 years, you're increasing 7% your risk of acquiring a serious version of COVID and getting infected. And obesity is more risk. Hypertension, 1.11% more risk. Diabetes doubles your risk factor. If you smoke, that increases your risk. If you have an obstructive pulmonary disease, 25% more risk. And if you have an immunosuppressive disease, 2.6% more likely to have a serious version of COVID. But there are few of these people within the general population. So we have to see how many people are there in the population with those risk factors. There's a medium that is called risk factors, higher risk factors. And that's what we have on the right. It's important to understand that people who are older than 60 years of age have a higher risk. But it's also important, there's an important risk for people between 40 and 49. This is an important group from 40 to 49 years old and male. Hypertension, diabetes, obesity, all of these have a higher fraction of risk involved in terms of getting sick with a serious version of COVID-19. Somebody could be over 60 years old and they have diabetes, and so that's going to be harder to overcome. So what we did is we developed a risk calculator, and this enabled us and people within Mexico to know if they have a background, these background problems, how likely are they to develop COVID-19? This shows how your risk increases the older you are. This is an important source of risk there. And you see with the blue line, that's the increase for men with their age, and the pink line is women. Men, as we were saying, are almost doubly likely to develop the disease, even 10 times more from people who are 20 to 70 years old. Next, please. Taking a look at these risk factors here, we can classify these risks as medium, high, and very high. Next. Next slide. We also developed, this is the risk calculator that I was telling you about. You can find this on our EAMS page, or you can access this directly with the QR code through your cell phone, whichever you would like to try out. This risk calculator and what comes after this, we're going to show you 3 examples here. Here's the risk for a woman who's 25 years old. She has a 12% risk. This is an average risk of developing the disease. Next, this is for a man who's 59 years old, who is obese. So he has 3 risk factors, or we consider age to be a high risk factor: his age, his sex, and his obesity. And he's 77%. That's his risk factor of developing serious COVID-19, serious version of COVID-19. So you have that in yellow as high risk. This is another example for a man who's 75 years old, obese, has hypertension and diabetes, and also smokes. And he has a very, very high risk of developing a serious version of COVID-19. After all of this, the calculator gives you recommendations after it's calculated your risk. If it has a very high risk, we say you are people, you're someone who really needs to stay at home. You really should not go outside. You must really be very careful because if you get the virus, you're going to develop a serious version of the disease. Now, these people are people that we want to really take care of themselves right now. Please be very careful. And also, don't let other people bring the disease home to your house. These are older people who have limited mobility. Yeah, let's go to the next one. Also, the Institute, after we created this calculator, we thought, what can we do with people who we know are in a high-risk group? And if some of them, if they're symptomatic and they have a positive test, what do we do with them when they don't develop a serious version of COVID? Or perhaps when we see them and attend to them, they aren't showing those signs, symptoms that we thought they would. Now, as Robeldio announced, we have this project where we're going to have this hospital specifically as a COVID hospital. We want to take these people who are higher risk here to this hospital because these are people who perhaps, even though they haven't developed the disease, over days they may develop pneumonia or some sort of complication from pneumonia. So we'd like to give them a place as if it were a hospital where we'll be able to monitor them and where we'll be able to give them close observation and communicate with them. So it isn't a hospital, it is a place where we can observe these high-risk groups. What have we seen? People who have diabetes and are not in control of their diabetes, or they have high blood pressure and they're not in control of their high blood pressure, it could be better for them to be at a place like this, where the care, because the care that they get at home maybe is not optimal. So in some cases, older people, we could have them here and monitor them. And this monitoring, who's going to be in charge of that? Doctors, the majority of them family doctors, and they will be there and they will have more expanded specialists and medicine at their reach. And family members would also be able to come, and we'll be able to have 50 patients there. These are people who have high blood pressure out of control, and we would be monitoring them to see that they don't develop a more severe version of COVID. We've seen that up to 24% of patients do require intubation of people who are hospitalized. We believe that we could lower the number of patients who need to be intubated if we control them from the start. We have 192 beds for patients with a lesser version of the disease and 25 beds in the ICU. We're going to have a evaluation procedure at the beginning so that we can see how serious the patient is. That's the triage. So some people are high risk but don't actually need to be hospitalized, and we would be sending for them with an ambulance, or if they can come to the hospital care location themselves, that would be wonderful too. We're going to have X-rays here, we're going to have a septic area, pharmacy, and also diagnosis units. We will also have a place for doctors, for residents, a cafeteria, and everything that they need, a waiting room, as well as places to change. We would also have personal protective equipment that would be required by these doctors because these are isolated areas. So we've asked for these hospital services, ambulance, food services, garbage for all of our health professionals. This is the design of our care unit. We have 50 beds around a central area for nurses and doctors, and this is for care and also intensive care. We can see that there's a greater visibility so that they can see all around them. That's all. Thank you. Let's go to the video. This is the video for our care center. Thank you. Excellent. Thank you, Dr. Victor Hugo Borja. Yes, that's why I told you there was an exciting surprise. This is very good news about the risk calculator and this new care unit in the Hermano Rodriguez Autodrome. Yes, you, Araceli? Oh, how are you? Carlos Guzman from Hágano Noticias. Two questions. My first one is split into two. That date, May 13th, to begin operations at the Autodrome, is that for real? Is that fixed? And now you presented to us a couple of minutes ago that it was the estimate of no intervention was reduced to 64%. What is the guess for when we can restart some economic activities? June 1st? Is that going to go ahead in the country? And the third thing is, if you could mention a little bit what you talked about with the senators, the Mexican senators before May 1st, who said that they had talked to you and that they were going to be suspending the extraordinary sessions in the Senate. Thank you, Doctor. Thank you. Is that date set? It can be modified to earlier. We may be doing a progressive opening by the 13th. The other two questions, those situations, thank you for asking, Carlos. Now, our pandemic curve represents the intensity of transmission day by day. This is reflected in seeing the number of contacts that happened 7 days before, because the transmission of the contact happens, and then transmission happens at that moment, and then 7 days later, you may or may not show symptoms. If that transmission persists, there's always the risks that, besides the cases that we've had in the last 14 days, because we've been putting a lot of emphasizing on people who have been infected in the last 14 days, there may be higher propagation and transmission rates. So the good news, that good piece of news of that lowering 3/4 basically of the magnitude of this pandemic, well, we need to take that with two different grains of salt. It's a very encouraging signal of Mexico's success. And we can attribute this, in my opinion, to Mexican society, because people who flattened this curve were Mexicans. Every single person who voluntarily, in an organized way, solidarity way, in a solid way, decided to stay home and not pass on their contagion to other people. So I think we really need to recognize and appreciate that and admire people for doing that. But we do not need to interpret this as a sign that we can anticipate suspending these measures. If we suspend any of the measures, before it's time, we're going to have another outbreak.
vamos a tener un
We're going to
repunte
have an
nuevo de la epidemia.
upspike
Por eso he
again, an
dicho una y
upturn
otra vez,
again.
sí y solo si
If and
nos
only
mantenemos
if
con
we
estas
continue
intervenciones
with our
hasta un
actions
momento razonable
to a
en
reasonable
donde
moment
la
when the
cantidad
number
de
of people
contagios
who are
se
being
puede manejar
transmitted,
de una manera
or who are
semejante a
being
la fase 1.
transmitted to the virus, that we go
Noten
back to
ustedes
being
que
more in
si
phase
dividimos la
1.
curva epidémica
It
en
doesn't
dos,
mean that we can
es como
divide
verla
the
con un
pandemic
espejo.
curve into two.
Lo que ocurrió
What
al
happens at
inicio
the beginning,
fue
it
de
goes
subida,
up.
lo
And
que
so
ocurre
what
después
happens
es de
after is that
bajada,
it's going to go
y
down.
los
So
eventos de
the
baja
events for
transmisión aquí en
low
la fase 1
transmission in the
pueden
first
ser
phase
comparables
could
con los eventos
be
de baja transmisión
compared to low transmission
en la
phases on
salida.
the
Pero
output.
eso se tiene que hacer de una
But
manera
this
muy
has to be done in a
organizada.
very organized way.
Eventualmente tenemos que hacer
And what we
lo que
have to
llamamos
do
desconfinamiento,
is
la liberación de las
slowly
actividades.
liberate, slowly
No se puede
free our
mantener
activities. We can't
perpetuamente una
just
sociedad
suddenly
en este
have,
estado
we
de
can't have people in this
limitación de
limited
su movilidad en el
mobility
espacio público. No se puede.
period
Porque
for
aún en las
long.
sociedades que son equitativas
Because
o más equitativas,
societies that
México no
are
tiene
more
una
equal,
distribución justa de la
well,
riqueza, es
not like
una de las
Mexico, where
sociedades
we have
más
this really
desiguales
huge
en términos
gap between
económicos y
rich and poor.
sociales. Y
But
aún en las que
even
son
people who
más o
are in a
menos
society that are
igualitarias,
more
no se puede,
egalitarian,
porque tiene
they know that
consecuencias
they can't
importantes.
come out of
En una
isolation
economía
yet.
como la
And in the
mexicana, en una
community
sociedad que
in the
tiene al
Mexican community,
50% de las personas
50%
viviendo al
people are
día,
living day by
si
day.
nos mantenemos de esta
And if we
manera,
continue like
empezamos a
this, we're
causar
going to
graves y
start to have
grandes
serious
daños a las
damage to
personas, a
people,
su
to their
bienestar.
well-being,
Entonces,
because it's the
en todo
economy.
momento, cada
So at
momento,
every
cada día,
moment,
cada
every
minuto
minute, every
del manejo
day
de esta
in
epidemia,
managing this pandemic,
desde la
just
planeación
even back from
el 3 de enero,
planning on
cuando
January
empezó,
3rd, when all this
tenemos
started,
estos dos
we've had these
elementos
two
por
elements to
considerar.
consider.
Hoy tuvimos una
Today,
nueva
we had a
sesión
new
semanal
weekly session
con las y los
with
secretarios de salud de
our
los estados,
health
la tenemos todos
ministers.
los
We do
martes.
that each Tuesday.
El
Dr.
doctor Benítez, secretario
Benitez,
de Salud de
the Minister
Hidalgo,
of
y la
Health
doctora
for
Gloria
Hidalgo,
Molina
and
de
Dr. Gloria
Tamaulipas,
Molina
entre
from
otros médicos,
Tamaulipas, among other
expresaron una
people,
inquietud que me parece
expressed
totalmente
concern that I thought
adecuada,
was very
legítima y muy
legitimate,
oportuna,
timely, and
que es
important.
cómo
How do we
reconciliamos el mensaje
reconciliate,
del
how do
momento
we
en que se termine
reconcile
la jornada
this
nacional
national
de sana
campaign for
distancia
Susanna Safe
el 30 de
Distance?
mayo, de origen
We
planeada
had
para esa
planned on
fecha,
ending this May
cuando
30th.
algunas
How do we do
entidades
this when in
federativas, en
some
el caso de
states
Hidalgo,
like
en el caso de
Hidalgo and Tamaulipas
van a estar teniendo
are
ascenso de su
having,
curva
at that
epidémica.
exact moment, they're going to be having a
Entonces, si
spike
aquí
in their
damos un mensaje
pandemic
a la
curve.
nación
So that's
diciendo,
why we
ya
gave the
estamos en el
message to the
pico, vamos
nation
para
saying,
abajo,
hey, we're at the peak
la
and we're
sociedad
going down.
tamaulipeca o
But
de
then
las
the
ciudades en
Tamaulipecans,
Tamaulipas o de
what
Hidalgo
do we
o de
say
las
to
demás
them or to
entidades,
other
no le
states
hace
when that
sentido
doesn't make sense
y
for
le va a
them?
reclamar con
And
toda
they're right.
razón a
That's
su
totally
secretario o
right. And
secretaria.
that's what their
Entonces,
ministers of
ese
health are
señalamiento me
saying.
pareció
That's
absolutamente
totally
legítimo y lo
legitimate
que
concern.
acordamos
And what
es,
we agreed on is
vamos a
this.
ir
We're
dejando
going to
claro
make it
que
very
una
clear that
cosa son las
one thing
medidas
are
generalizadas
generalized national
nacionales,
measures
muy
that are very
oportunas,
timely,
muy
very
útiles,
useful,
muy
very
efectivas
effective
para hacer
moments
epidemia.
where they're going to hit the
Entonces,
spike
todavía
and peak
faltan
of the
muchas
pandemic.
ciudades que van a tener su
So
momento
many
epidémico
states are going to have their
una
pandemic
semana,
peak
2
1
semanas,
week,
3
2
semanas,
week, 3,
6 semanas
6 weeks
después de lo que
after
ha ocurrido
what is
en
going
la
on
Ciudad de
in
México, que
Mexico
fue la
City,
primera
which was
en
the
tener la
first
epidemia.
state
Y lo
to
vamos a hacer,
have confirmed
ya lo estoy
cases.
haciendo en este momento,
So we
dejando en
want to
claro,
make it
si usted
very
vive en
clear. If you
Tamaulipas, si
live in
usted vive en
Hidalgo, if
Hidalgo,
you live in
si usted vive en
Tamaulipas, if you
Veracruz,
live in
si usted
Veracruz, if
vive
you
en
live in
Yucatán,
Yucatan,
sepa que,
know that
entre otras, en
among
Morelos,
other
por
states,
ejemplo,
including
sepa
Morelos,
que en
that
su
in
entidad
your
federativa, en su
state,
estado,
there's
todavía falta,
still,
porque todavía va a existir
we
un
still
periodo
have a period, a
epidémico
pandemic
en
period
las distintas ciudades,
before
igual que
the
ocurrirá
peak is
en
going to
varias
happen
otras.
in many states.
Ese es el
That's the
mensaje que quiero
message
dar
that I
este
want to
momento.
give right now.
Gracias,
Thank you, Carlos. Now, if the curve is not
una
flattened
excelente pregunta
nationally, what's
también.
going to happen? That's an
La
excellent
curva
question.
no se puede
The curve cannot be
dibujar a
drawn
nivel
on a
nacional.
national
Por eso es que
scale.
no
That's
presentamos
why we
curvas
don't
nacionales.
present
Los
national
propios
curves, because
matemáticos y
mathematicians
nos
themselves, they
recomendaron
recommended,
como
as
epidemiólogos, lo sabemos,
epidemiologists, not to do
porque
that.
en realidad, si
Because in
pensáramos en la
reality,
curva
if we
de todo
think
el
of the
país,
country's curve,
que si hubiera
if there
una
could
posible
possibly be
curva
a
nacional,
national curve,
está
that would
compuesta de
be made up
curvas
of smaller
pequeñitas,
curves, medium
medianas
ones, little
y
ones,
grandes
big
al
ones,
interior que son
that would
de las
be
distintas
in the different
localidades. Imaginen
areas.
ustedes que
Imagine
México
if
fuera un
Mexico was a
continente
continent
y que estamos
and
viendo
we were
la
looking at
curva
the
de un
curve
país, la
in
curva
one
de otro
country
país,
and
la curva de
another and
otro país.
another.
No
They're
están
not synchronized.
sincronizadas.
they happen at different times. The peak happens at a different time. So we really can't have one single curve. At the end of the day, if we add up all our cases, we could have a curve in the country. But we're going to see that it would be a lot less if we hadn't taken these mitigation measures. It's going to vary among states. Tomorrow, we're supposed to be talking about the mobility statistics. And the pandemic curve in some states has decreased 74%, like in Mexico City. Maybe in Tijuana, it's a totally different country, quantity. In Cancun, it's another one. In Villahermosa, it's another one. And so we will be presenting those to see what the phenomenon looks like there. I think we have time for one quick question. Blanca? Thank you. Doctor, if you could please tell us about this meeting that was held. I understand that at 8 o'clock there's going to be another one. Is that true? I would also like to know if on June 25th, with this change of the spike of the highest number of contagions, if the end of the first pandemic cycle would still be June 25th, would that be the end of the first cycle? Thank you. That curve that we presented, that origin curve, that was based on the first prediction that was made at the beginning of April and was showing the end with about 95% of the curve resolved on June 25th. We've had 3 new rounds of updates for predictions, the most recent one last night. And the good news is that with following that peak, we're also seeing that we follow the number of cases. But up to a certain point, that might not be satisfactory because according to how the curve is smaller, it gets longer. So perhaps 95% of the cases will be completed further beyond June 25th. I'm sorry, unfortunately, that's the way it works. We can't win in every arena. But the quantity would be lower, but it would be longer. So just like I was explaining to you on the theoretical graph, the number of cases would be distributed over time. At the end of the day, we're going to have fewer cases, but the main contributing factor are objectives 1 and 2. Move the peak and make it lower. Oh, the meeting. Yes, about the meeting this morning, that is a meeting that we do every Tuesday with 32 health ministers. What can I tell you? It's always such a positive environment. Everyone's very committed. All those health ministers, those state health ministers. Tonight, yes, we are going to have another meeting. We have that from time to time. I will ask someone how many there have been, but it's going to be with our president. And we're going to have a direct and timely follow-up from him for all these technical elements in terms of acquiring materials, in terms of epidemiological testing, in terms of hospital retrofitting. And for each element, we're going to talk about it. We're going to fine-tune changes, adjustments, details. And then tonight, we're going to take a look at what are the new projections, what are the expectations for distributions of new epidemic outbreaks in cities that are close to having those outbreaks or who are passing through, who are experiencing those outbreaks right now, and also what Dr. Borja projected, what he presented about this Hermano Rodriguez hospital care facility. And what we were talking about, we'll be talking about retrofitting in the Valley of Mexico area. I think we're done. It's 7:59. We'll continue tomorrow. Thank you so much. Good night.